Assalamu alaikum. Welcome to the largest online platform for BDS students, Access Dental School. Journey towards excellence is the motto of Access. So as promised, Access is gifting us with excellent programs and competitions every day. I hope everyone has joined and are ready to witness the most awaited competition. So please take your chairs and be comfortable, as tonight we have joined the 4th episode of paper competition initiated by Access Dental School, and tonight's topic is dental calculus. Throughout the competition, I will be your moderator. I am Saima Jahan Muhurto from Sapporo Dental College and Hospital, session 2017-18. With the gift of amazing and knowledgeable sessions, Access has gave us the opportunity to meet and greet honorable teachers across the country and abroad. It is my utmost pleasure to introduce to our honorable respected judges. So firstly, I would like to introduce our foreign judge, Dr. Mayur Kaushik, Professor and Head of Department of Periodontology and Implantology, Subharti Dental College and Hospital, Uttar Pradesh, India. Next, I would like to thank Access for giving me the opportunity of being a part of this program with my own college, Sapporo Dental College's principal, sir. So ladies and gentlemen, introducing Professor Dr. Asad Zaman, sir, principal of Sapporo Dental College and Hospital, Dhaka, and Vice President of Bangladesh Periodontology Society. Last but not the least, our renowned mentor and guide, our favorite of Access Dental School, Dr. Anupam Podder, sir, Associate Professor and Head of Department of Periodontology and Oral Pathology, Dhaka Dental College. Thank you so much, respected judges, for being a part of today's show. Finally, I would like to introduce our brilliant presenters of tonight. Rakib Hasan from Gonoshasthaya samaj vittik Medical College, Samiha Saiyara from Dhaka Dental College and Hospital. Finally, Shahriar Hussain from Pioneer Dental College and Hospital. Assalamu alaikum, honorable judges. It will be very helpful for the presenters if you could share some of your valuable advice with our presenters and audience. I would like to start with Dr. Mayur Kaushik, sir. If you could please share your speech with us.
Jai Hind and a very good evening to everyone. It is an honor for me to be invited as a foreign judge in this very esteemed gathering. As a periodontist and implantologist, I always feel that our branch has been left behind a little because over a period of time, we haven't been able to keep a balance between how much we read and how much we actually do. So this is my advice to all the young periodontists, the next generation as such, that please remember no branch is an island as such. Ultimately, all of us are dental surgeons first and specialists next. So what we have to keep in mind is that it is our clinical skills as a periodontal surgeon which will keep us afloat in the near future. So ultimately, my emphasis always has been on the applied aspects of topics. For example, just 1 hour back, I was convincing a patient with regard to the importance of scaling. And the main problem that we face as a periodontist is that tangible results are not there, and neither is the pain part there with regard to periodontal disease. So what I did was I took a photograph of the calculus and I showed it to the patient. And then I told the same thing, that if this remains for a longer period of time, ultimately the tooth would be lost as such. So that is what I was just thinking, that what a coincidence. I'm supposed to moderate a session on dental calculus, and just now in my clinic, I'm just showing the photograph of calculus also to this thing. So what I mean to say is that ultimately we are all clinicians, and once we have read the theoretical aspect, we should be able to apply that thing in our clinical practice. That is what will be taking periodontology, which is at the heart of each and every specialty of dentistry, to the next level. So thanks again, Access Dental School. Thanks a lot for making me worthy, considering me worthy of this honor. And thanks a lot, Anupam sir, for involving me in this session. I'm sure it will be a bright session, and this is my word of advice to the young periodontists of the next generation, that please keep on flaunting your work. It is our work, our periodontal surgeries, which will determine the future of our specialty. See? Thanks a lot. Thanks.
Thank you so much, sir, for your valuable words. We are beyond excited to have you here. Next, I would like to request Professor Dr. Zaman, sir, to please share some of your knowledge with us and for the audience.
Thank you very much. I'm really honored being a part of this session and as a judge. And I would like to thank Axis School, Dental School, for arranging such a wonderful, what should I say, competition on periodontology. As we all know, as your Mayur told, in our
Saima, maybe it is net connection problem.
These are extremely sorry, audience. I would request you to, I guess sir is having some network issues, so no problem. Let's move forward. We can again hear from Dr. Zaman, sir. So I would like to request Dr. Anupam Podder, sir, to please share your words with us.
Sorry, I'm disconnected. Sorry.
Please.
Sorry.
Okay, sir.
Problem we have with the online. Sorry.
No problem, sir. Please, sir, continue.
Again problem.
Sir, can you hear us?
Can you hear me? Sorry.
Yes, sir.
Yes, sir.
Sorry, again, I was disconnected. So it is a very wonderful program. As I told you, it will definitely encourage our young dental surgeon to take periodontology as a specialty. What I hope is that this program will be very successful, and I hope the today presentation will be wonderful, as I also followed the presentation before. So I wish best of wishes to all the participants, and we are eagerly waiting for your presentation. Thank you. Thank you very much.
Thank you so much, sir, for sharing the words of your wisdom. Now, I would like to request Dr. Anupam Podder, sir.
Thank you. Saima Samin Jahan Muhurto, the student of Sapporo Dental College and the third page, for your nice introduction as well as nice moderation of today's seminar. Today's topic is the dental calculus. Is the basic topics, and the group of this session, name of the group of this session is collagen. This is important in dental implants. Like Dr. Mayur, he's always doing every day. He's doing maybe 2 to 3 implants or more, and he's always encourage our his student, and I saw his activity daily. He's very much appreciating. Thank you, Dr. Mayur. Today's honorable judges are my teachers, Professor Dr. Asad, Principal, Sapporo Dental College, and other judges, my friend Professor Dr. Mayur Kaushik, HOD Periodontology, Subharti Dental College, UP, India. Thanks both of you from core of my heart, and congratulate both of you. I think our judgment will be fair and will encourage to our presenters. Our presenters are Rakib Hasan is a student of Gonoshasthaya Samaj Vittik Medical College, Dental Unit, and Dr. Samiha Saiyara from Dhaka Dental College, and Dr. Shahriar Hussain from Pioneer Dental College. Congratulations all you for fearless participants and wish for your great success. Finally, I would like to thank the management team of Axis Dental College for your excellent cooperation with us. I think this kind of program is helpful for our students to reduce fairness and encourage them and brightness in future paper presentation in nationally and internationally. Thanks all.
Thank you so much, sir, for your words. And again, I would like to also thank Axis Dental School for this opportunity and say all the best to the presenters. So dear audience, I know you have been eagerly waiting for this competition. I promise to take only 1 minute to read out the rules of this competition. So here are the extremely simple rules. Each participant will get 10 minutes for their presentation. After 8 minutes, I will be notifying them. Then within 2 minutes, the participants need to finish their presentation. Finally, after the presentation, there will be a discussion among the judges. So we wish to have a very amazing competition right now. So first, I would like to request our first presenter, Rakib Hasan from Gonoshasthaya Samaj Medical College, to please share your presentation.
Thank you, Samiha. Thank you, Simon. I would like to thank our respected Honourable Judges, Professor Dr. Asad Zaman, Professor Dr. Mayur Kaushik, and Professor Dr. Anupam Podder, sir. And my two fellow participants, the moderator and the viewers who are watching this program right now. Assalamu alaikum. I'm Rakib Hasan, currently studying at Gonoshasthaya Samaj Vittik Medical College. Today, in this paper presentation, I am going to discussing about the few points of dental calculus. Before going to my presentation, I would like to thank Axis Dental School for giving me this opportunity to present my presentation and organizing such an amazing program. And I also thank to our honorable judges to present here and judge us. Without any further delay, I'm going to my next presentation. So my topic is dental calculus. Presented by me, Rakib Hasan, session 2017, College, Gonoshasthaya Samaj Vittik Medical College. Here are some contents I am going to discussing about introduction, definition, history, classification, and the prevalences. Now I'm going to discuss about the introduction, how it is formed. Once a tooth erects, various materials gather on its surface. These substances are frequently called tooth accumulated materials and deposits. They are classified as soft deposits and the hard deposits. Soft deposits are acquired pellicle, microbial plaque, material alga, and the food debris. And the hard deposits are calculus and the stains. So here are some definitions. There are acquired pellicle. Following tooth erosion or dental prophylaxis, a thin salivary layer on the acquired pellicle covers the tooth surface. According to WHO 1978, dental plaque is defined as a specific but highly variable structure entity resulting from the sequential colonization and growth of microorganisms on the surface of the teeth, and restoration consisting of microorganisms of various strains and species are embedded in the extracellular matrix composed of bacterial metabolic products and substance from serum, saliva, and blood. So what is material alga? Bacteria alba is actually refers to soft accumulation of bacteria and tissue cells in the lack of organized structure of dental plaque. Now the definition of calculus. As you know, in the according to Karenza, calculus consists of mineralized bacterial plaque that forms on the surface of natural teeth and dental prosthesis. Here are some other definitions was given by Green, a deposit of inorganic salts composed primarily of calcium carbonate and phosphate mixed with food debris, bacteria, and disformated epithelial cells. And Schroeder also said the mineralized dental plaque that is permeated with crystals of various calcium phosphates. Now, we have to know how it is came up to us and who introduced us in the calculus. We have to go the history of the calculus. So the calculus was recognized as a clinical entity in some related to periodontal disease as far back in the 10th century. Van Leeuwenhoek in 1683 describes microorganisms in tartar. He called them animalcules. And in 1728, Farnsworth termed it tartar or slime and referred to it as a substance which accumulates on the surface of the teeth and which becomes found left there as stony crust of more or less considerable volume. Now, I'm going to discuss about the classification of the calculus. So the calculus is divided by two parts. One is supragingival calculus and the other is subgingival calculus. Now the supragingival calculus is tightly adherent calcified deposits. This forms on the clinical crown of the tooth and the free marginal gingiva. It is absolutely clinically visible and it's also called salivary calculus because it forms from the saliva. The two most common locations for supragingival calculus where it is developed more, the buccal surface of the maxillary molar. Here you can see, because saliva from the parotid gland flows over the facial surface of the upper molar by the parotid duct. We can see here it is visible on the crown. And the other part is the lingual surface of the mandibular anterior teeth. Because saliva from the sublingual glands flows over the lingual surface of the teeth. Now the subgingival calculus, how it is actually formed. It is formed from formed on the root surface below the free marginal gingiva, and it is also called cerumal calculus because it forms from the gingival exudates. It is mainly not visible on the routine clinical examination because it is located below the crest of marginal gingiva and extend to the bottom of the pocket. As you know, the color of this things is greenish black. And I'd like to discuss about the prevalences, why it is most probably formed. The formation of supragingival calculus observed early in life in individuals, probably shortly after the tooth erected. As we know, most common areas of supragingival calculus is facial aspect of maxillary molar and the lingual surface of mandibular incisors. As it is goes, supragingival calculus continued as individual case. At 25 to 30 years old, it is maximum scores of calculus affected in individuals. By this time, facial surface had less calculus than the lingual or palatal surface. By the age goes over 45 years, these individuals had only few teeth without calculus deposits. Typically, they are premolars. And the subgingival prevalences is mainly occurs independently or in the interproximal aspects of areas where supragingival calculus is already there is existed. By the age of 30 years, all surface of teeth have subgingival calculus without any pattern of variations. Here are some references.
Recording in progress.
I would like to thank all the judges for hearing my presentation. Now I'm going to call Mr. Samiha to present the further presentation.
Hello, Saima. Saima, please introduce to Samiha.
Thank you so much, Rakib Hasan, for your presentation. Can I please request Samiha Saiyara from Dhaka Dental College and Hospital to take over the presentation?
Thank you, Saima Samin. Assalamu alaikum, Honourable Judges, Professor Dr. Zaman sir, Professor Dr. Mayur Kaushik sir, Dr. Anupam Podder sir, my fellow mates, and respected viewers. I would like to welcome you to my presentation. So today's topic is about dental calculus, which will be presented by me, Samiha Saiyara, currently studying at Dhaka Dental College and Hospital, session 2017-18. From my part, I will discuss about clinical features and composition. At first, I will discuss about clinical features. In this part, I will basically focus on 9 key points. At first distinguishing point will be color. In supragingival calculus, we will get that its color is white, creamy, yellow, or gray. And in case of subgingival calculus, it will be light to dark brown, dark green, or black stain. Next point is shape. In case of supragingival calculus, it will be amorphous, bulky, and extend over the margin of the gingiva, and shape is determined by the anatomy of teeth. And in case of subgingival calculus, it will be flattened to conform with pressure from the pocket wall. Following point will be consistency and texture. In case of supragingival calculus, it will be moderately hard. Newer deposit will be less dense and porous, whereas in subgingival calculus, it will be brittle, flint-like, and hardens and more dense than supragingival calculus. Subsequently, next point of consistency and texture will be size and quantity. In case of supragingival calculus, quantity has direct relationship to personal oral care procedures, physical character of diet, individual tendencies, function and use of increased amount of tobacco, and whereas in subgingival calculus, it will be related to pocket depth and development and progression of periodontal diseases. Next point will be location. In case of supragingival calculus, we will find this coronal to the gingival margin, and in case of subgingival calculus, it will be deposits present apical to the crest of marginal gingiva. Following point is source. In case of supragingival calculus, source will be from derived salivary secretion, and in case of subgingival calculus, it will be derived from gingival exudate. Next point is distribution. In case of supragingival calculus, it will be symmetrical arrangement on teeth, more on special surfaces of maxillary molars and lingual surfaces of mandibular anterior teeth, whereas in subgingival calculus, it will be related to pocket depth and heavier on proximal surfaces. And the second last point will be visibility. In case of supragingival calculus, it will be clinically visible. It can be directly or indirectly by using mirror with combination of retractor, light, or air. And in case of subgingival calculus, it will not visible on routine clinical examination, rather detected visually by blowing air. And the last point of the clinical features is attachment. In case of supragingival calculus, it is easily detached from the tooth, whereas in subgingival calculus, it will be firmly attached to the tooth surface. in this picture, we can see that it is supragingival calculus, and here yellowish deposition has been deposited at the coronal surface of the marginal gingiva. And in case of this picture, it is subgingival calculus, and here apical of the marginal gingiva is accumulated with greenish deposits, and it may be from periodontal pocket also. Now I am moving to my next topic, which is composition. We know that in case of composition, it is quite different between supragingival and subgingival calculus. At first, I will talk about supragingival calculus, which is consist of inorganic components 70 to 90% and organic components 20 to 30%. Inorganic component consists of 76% calcium phosphate, 3% calcium carbonate, traces of magnesium phosphate, and traces of other metals like monazite and calcite. Now we can see that principal components of inorganic content is composed of 4 components. Their percentage are shown in this pie chart, where we can see that calcium is the highest in percentage, which is 39%. After that, we can see phosphorus is 19%, carbon dioxide 2%, and magnesium is 1%. And traces elements of inorganic content is sodium, zinc, strontium, bromine, copper, manganese, and so on. Now we know that 2/3 of inorganic component is crystalline in structure. So let's talk about the crystals. In case of crystals, 4 distinct phosphate crystals can be seen under electron microscopy and X-ray diffraction studies. They are hydroxyapatite, magnesium with locite, octacalcium phosphate, and brucite. The percentage are shown in this slide. In supragingival calculus, hydroxyapatite and octacalcium phosphate are detected most frequently, and in case of subgingival calculus, magnesium with locite is present in high concentrations and same hydroxyapatite content. Brucite forms early calculus, and later calculus is formed by octacalcium phosphate, and mature calculus is formed by hydroxyapatite and with locite. Now we are going to organic content, which is consist of mixture of protein polysaccharide complexes, discoamated epithelial cells, leukocytes, and various types of microorganisms. In this part, we will talk about carbohydrates, salivary proteins, and lipids. At first, I will discuss about carbohydrate of organic content, which is 1.9% and 9.1% of organic content consist of galactose, glucose, rhamnose, mannose, glucuronic acid, and galactosamine. Sometimes arabinose, galacturonic acid, and glucosamine. Now, salivary proteins. 5.9% to 8.2% of organic component include most amino acids. And in case of lipids, 0.2% of organic component in the form of neutral fats, free fatty acids, cholesterol, cholesterol esters, and phospholipids. Now, we are going to subgingival calculus, which has composition similar to supragingival calculus with some differences. The differences are they are more homogeneous with equally high density of minerals, more magnesium with locite, less magnesium, less brucite, and octacalcium phosphate. The ratio of calcium to phosphate is higher subgingivally. The sodium content increases with the depth of periodontal pocket, and salivary proteins, they are not found subgingivally. We know that another important component of calculus is bacteria. So let's talk about the bacterial content of calculus. The percentage of gram-positive and gram-negative filamentous organism is greater within calculus than in the remainder of oral cavity. In supragingival calculus, viable aerobic and anaerobic bacteria have been detected, while subgingival calculus provides an excellent environment for further microbial adhesion and growth. There are some periopathogens such as Agrotibacter, Actinomycetum comitans, Porphyromonas gingivalis, and Treponema denticola have been found in the lacuna of both supra and subgingival calculus. Their high amount of calculus indicates that oral hygiene has been poor for months to even years. The increase in microbes creates higher porosities, lower the compressive and tensile strength of calculus. Mineralization of plaque generally starts extracellularly around both gram-positive and gram-negative organism, but may also start intracellularly. Filamentous organisms, diphtheroids, bacterioma, and Velionella species have the ability to form intracellular apatite crystals. In this particular slide, we can see three different figures. At the first figure, we can see that there are plaque and calculus on tooth surface. It is the outer surface, it is the inner surface, and this is the spherical area where focal calcification we can see. In this outer surface, cocci are attached, and in this inner surface, filamentous organisms are attached. In this picture, we can see that it is the figure of Agritibacter actinomycetin comitans, which have filaments at their cell surface. And this picture, we can see that adhesion of Porphyromonas gingivalis, which have fimbriae at its cell surface, which helps them invading host cells and go to the deeper layer of connective tissue. In this slide, we can differentiate between the microbial content of supragingival and subgingival calculus. In supragingival calculus, there is predominance of gram-positive filaments, next in frequency gram-negative filaments and cocci, and where separation takes place, gram-positive cocci seen. And in case of subgingival calculus, superficial layer composed of gram-negative filaments, and in deep and middle zones, gram-positive filaments predominant. So these are the references that I have used for preparing my slides. Thank you all for your patience, and I would like to extend my gratitude to Access Dental School for creating this wonderful opportunity of presenting this. That's all from my side.
Thank you so much, Samiha, Saiyara, for finishing this just on time. I would like to request our last participant for today, who is Shahriar Hussain from Pioneer Dental College and Hospital, to give your presentation.
Assalamu alaikum, everyone. Thank you, Muhurto. You have been very excellent tonight. And I'm going to start my presentation. My name is Shahriar Hussain, session 2017 and 18, and I'm from Pioneer Dental College and Hospital. And first of all, I want to let my honorable judges know that it's a very, very, very big honor for me to be able to present in front of you, especially Professor Dr. Asad Zaman sir, Dr. Mayur Kaushik sir, and Dr. Anupam Podder sir. And I also want to congratulate Dr. Anupam Podder sir for being awarded the Global Outreach Dental Award 2021. And with that, I want to straight dive into my presentation. So today we are presenting on dental calculus, and my contents on dental calculus includes different phases of calculus formation and different theories that we have about calculus formation. And I will also talk about the specific calculus detecting instruments and anticalculus agents. And after that, I will conclude the dental calculus presentation. So already we know that calculus, how calculus is formed. Calculus is basically formed from the soft plaque, which is hardened by the precipitation of mineral salts. This is the main point of calculus formation. Also, there are different phases of calculus formation. The calculus goes through different phases to actually be a calculus. And I will have a look at that. And firstly, the first phase of calculus formation is pellicle formation. Firstly, a pellicle will be formed, and it will act as a nidus. And the other microorganisms and other factors and contents of calculus will actually locate this pellicle and form calculus around and surrounding it. And the second phase of calculus formation is the adhesion and attachment of the bacteria. Then the next phase of calculus formation is the colonization of the bacteria and plaque maturation. And then this dental plaque will be mineralized and the dental calculus will be formed. So I will go a little bit deep into this. First, let's talk about the pellicle formation. What is pellicle? A pellicle is actually saliva-derived layer. It's very thin and homogeneous. It covers the tooth surface. And here we can see that it's written, it is derived from the components of saliva, but it can also be derived from cervicular fluid and the bacteria and host cells also. And this pellicle consists of mainly mucins, which is a glycoprotein, Also, it contains some enzymes, proline-rich protein and histidine-rich protein, and also phospholipids. And then the next phase of calculus formation is the transport of the bacterium to the surface. The bacteria will be transported into the tooth surface in the pellicle layer, and then it will initially attach to the surface. The bacteria will reversibly adjust to the bacterium through long range and short range forces. By this long range and short range forces, the bacterium and the surface will be connected, and those forces includes van der Waals attractive forces and electrostatic repulsive forces. And then we have the final attachment of the surface and the bacterium. This is a very firm attachment between the bacterium and the surface, and this is achieved by specific interactions. It can be ionic bond, it can be covalent bond, and also it can be hydrogen bond. And then the next stage of calculus formation is the colonization and plaque maturation. In the previous phase, we learned that at the end of the previous phase, there was a firm attachment between the surface and the bacterium. And when this firm attachment is fixed, and then it starts to grow and it forms microcolonies or biofilms. And from there, the bacteria starts to grow and make a lot of colonies, and the colonization occurs, and then the plaque matures. So who actually colonizes in this and forms of plaque formation? There are two types of colonizers: primary colonizers and secondary colonizers. Primary colonizers include Streptococcus, Streptococcus mutans, Streptococcus sanguis, and Actinomyces species. What they do, they actually use the oxygen in the surface area or in that specific site in the area. They uses the oxygen and makes the environment very suitable for the anaerobic bacteria. And then the secondary colonizers come and forms the colonies in that specific areas. So the secondary colonizers will never form their colonies in clean and smooth surfaces, because those surfaces will not be very suitable for the anaerobic bacteria. Okay. Secondary colonizers also includes Prevotella intermedia, Prevotella loci, and Porphyromonas gingivalis. Okay, and the final stage is the mineralization. I have already mentioned that the mineralization occurs by the precipitation of the minerals, and now we have to know where the minerals come from, sources of the minerals. Okay, in case of supragingival minerals, the main source is the saliva, and in case of subgingival calculus, the main source of the minerals is gingival cervicular fluid. Now I will talk about the theories of calculus formation. This is basically the theory how the dental plaques calcifies into calculus. If we look closely into these theories, we can actually divide those theories into two basic main principal categories, which includes mineral precipitation and seeding agents. These are the two main basic principles of all the theories. Mineral precipitation, how it works, it actually it happens by the saturation of the calcium and phosphate ions. It may be due to the raise in the pH of the area or the saliva. So there is mineral precipitation. Then we also have the seeding agents. What seeding agents do, they induce a small foci of calcification, and then they help to calcify the mass. Okay. So few proposed theories of calcifications are booster mechanism, epitectic concept, inhibition theory, transformation theory, bacterial theory, and angiomatic theory. I will go into deeper booster mechanism. So how booster mechanism works? So first, I want to mention that the booster mechanism is actually the the mineral precipitation. Its main principle is the mineral precipitation. So how it precipitates the minerals? Firstly, there is loss of carbon dioxide, which actually increases the salivary pH. Due to increase in the salivary pH, the phosphoric acid dissolves. The dissociation of phosphoric acid occurs, which increases the phosphate ions. And due to the increase of the phosphate ions, there is calcium phosphate crystals are formed. And this is how the mass is calcified.
I would like to inform Shahriar that we are 8 minutes up. So we have 2 minutes.
Okay. So I'm moving forward firstly into my second theory, which is epitectic theory. And in this, what happens, the seeding agents induces small pocket of calcification, as I have already mentioned. Also, the carbohydrate proteins initiates the calcification by removing saliva by chelation. And the crystal is formed actually by another component, which is similar to hydroxyapatite crystals. Also, we have enzymatic theory. The phosphatase enzyme is present in saliva. It hydrolyzes the organic phosphates and produces inorganic phosphate, which precipitates calcium salts in the calculus and forms the calculus. The inhibition theory is that there are possible substances such as pyrophosphate and other polyphosphates, which inhibits the formation of calculus. But in the inhibition theory, these substances are absent. The substances are absent from the site of calcification, but they are present in a site where there is no calcification is occurring. So this is how it actually promotes or does not inhibit the calcification. And then moving forward to the specific calculus detecting instruments, we have perioscopy, detector, diagonant, and others are perioscan and key laser, which also removes the calculus as well as detects the calculus. Here we can see some of the pictures of perioscopy and perioscan. Okay, what are the anticalculus agents? The agents includes dissolution agents, acids, alkalines, chelating agents, silicones, ion exchange resins. Also, it includes antibiotics like nidamycin, antiseptics like chloramines. Inhibition crystal growth, it actually inhibits the growth of the crystal, which includes vitamin C, sodium fluoride, zinc salts. Okay. In conclusion, I want to say that bacterial plaque and calculus, they are the main etiological factor in development of our periodontal diseases, and they have very important role in progression of periodontal disease and our gingival health. So the removal of subgingival plaque and calculus at the cornerstone, at the main point of our periodontal therapy. So this is a very, very important topic for all the clinical dentists and periodontists. And these are the references of my presentation. And I like to thank my judges and moderators and everyone else for being so patient and excellent and listening to me. Thank you. Assalamu alaikum.
Thank you so much, Shahriar, for this excellent presentation. I hope the audience and the judges have loved all the participants' presentations. So just hearing all of this, I myself was nervous that how amazingly everything is going and are they going to finish this in time? So it was an amazing session. I hope that the judges loved it. So now I would like to request the judges to take 15 minutes and discuss about all the presentations and let us know any questions that you have and throw the questions to the participants. So firstly, I would like to request Professor Dr. Asad Zaman, sir, if you like to share anything.
First of all, for me. Okay.
He forget. Okay.
So, okay. Thank you very much. All presentation was very good, and we really enjoyed the presentation. Everyone's presentation was, I would say, wonderful. And one thing I want to appreciate that that you prepared your slide in a very systematic. So my question is, calculus, what is the clinical significance of this calculus? Anyone can answer. What is the clinical significance of calculus? Anyone can answer.
Sir, my apologies. I would like to please interrupt. Could you please, sir, mute one of the channels? We are hearing echo. Thank you so much, sir.
What is the clinical significance? Why we are so much concerned with calculus? Anyone can answer? What is the clinical significance of calculus?
Sir, because it may cause bleeding, and after that periodontal pocket and periodontal disease can be formed.
Periodontal disease can be formed.
So
bleeding in
can
plaque
occur.
and gingivitis.
Bleeding can occur and gingivitis after that, and after that periodontal disease.
Anyone? Is it the primary etiological factor of periodontal disease, or it is a secondary etiological factor? Anyone can answer. Calculus is directly related to gingivitis or periodontitis, or indirectly? If it is directly, why? And if it is indirectly, also why? How? Anyone?
So it is closer to the periodontal pocket. So I think it causes the periodontal diseases, and also causes the inflammation, gingival inflammation.
Anyone can answer? Come up with the what should I say? The correct answer.
The calculus is the contributing factor in periodontal disease.
Contributing factor. It is a primary or secondary etiological factor of periodontal disease.
It's a secondary.
Okay, thank you. Who answers? Secondary.
Shaharia.
Secondary etiological factor. Sharia. Okay, good. Why it is secondary etiological factor? What happens if the calculus is there?
Sir,
what is the problem? What the problem
it
patient will face?
Contact. It has a very close contact with the gingival tissue, and it can irritate and cause the inflammation of gingiva. Also can cause bad breath.
Your secondary answer is right, but your why it is secondary, but it is not right, I think.
Calculus, the whole of the calculus is calcified, or some part of the calculus remain uncalcified?
So not the whole part of the calcified.
Which part is uncalcified? Okay. One simple question. Calculus, if there is a calculus, is there one of the enhancing factors of retention of dental plaque? বাংলায় বলে যদি ক্যালকুলাস থাকে সেখানে কি প্লাক বেশি জমবে না জমবে না, আর ক্যালকুলাস থাকলে প্লাক কি পেশেন্ট কি প্লাককে রিমুভ করতে পারবে কি পারবে না? এটা কি ক্যালকুলাস কি ওয়ান অফ দা রিটেইন ফ্যাক্টর অফ প্লাক? Anyone can answer? Okay, thank you. Thank you very much. It is calculus ki kore? Calculus increase
Thank you so much, Professor Dr. Asad Zaman, sir, for your questions. I hope the participants are still confident and did not get much nervous. I would like to request Dr. Mayur, sir, to please let us know your questions.
First and foremost, heartiest congratulations to all the three presenters. Okay, all of you are graduates in final year BDS right now or doing MDS? Hussain, Samiha, Rakib, all three of you, 17-18 session. So,
Only third
like,
year, third phase.
they're in third year MDS.
Third year BDS.
Third year
We-
BDS. So, BDS,
we,
that
we
is
don't
what.
have we don't have a sub-specialty in periodontology in our country.
Okay, sir. So they are third year BDS right now.
And
So
some of them
hats
are
off to
Yes.
hats off to all three of you. My heartiest congratulations to all three of you. The confidence level, the speaking level, and as Sir Asad sir rightly pointed out, the cohesiveness of the presentation. See, generally speaking, whenever we join MDS, we say three main things we have to learn in MDS, which we haven't learned during BDS. Orational skills, that is personality development, clinical skills, those surgeries which we haven't done during BDS, and finally theoretical. We tend to learn evidence-based theory, authors, etc.
Yes.
So that orational part, first and foremost, heartiest congratulations to all three of you, the confidence level, the way you present it, and the cohesiveness. I'm really impressed. I'm really impressed. Okay. Now, coming to the questions, just one or two, maybe we can answer as a continuation of Asad sir's question. As sir said, and you answered also, that calculus basically is a secondary factor. It's a contributing factor. It is not as such directly pathogenic. So what is actually pathogenic? Any one of you can answer. What is pathogenic, which causes the actual periodontal disease as such? What is present on top of the calculus, which actually causes the disease? One of you, I think, Rakib in the beginning mentioned. So Rakib is here. Rakib, are you here? Rakib, I cannot see. Okay. Anyone can answer. Hussain, Samiha. We say the plaque which is present on top of calculus, that is the actual factor which is causing periodontal disease. Okay. So who said yes? Rakib. Acha, Rakib, I cannot see you. I cannot see Samiha also actually.
Yes, sir. Dental
all of
plaque.
you are here only. Okay.
Yes, sir. Dental plaque.
Dental plaque. So now dental plaque, suppose our next question is that dental plaque is a biofilm. But the word which Karenza uses is that as a biofilm, dental plaque is unique. So biofilms are ubiquitous. They are present everywhere in nature. A normal pipeline would be having a biofilm inside. So what is so special about plaque biofilm that is different from other biofilms which are present in nature? Yeah. Again, given in Karenza as such. So this again, I mean, this would have been extra marks for whoever would have answered as such. But please refer your Karenza again. So normally speaking, we say biofilms are 70 to 80% glycocalyx, that is the exoskeleton, and 20 to 30% maximum microorganisms. Plaque biofilm, it is reverse. 90% are microorganisms, just 10% is glycocalyx. So the way you had covered up those microorganisms as such, that was very nicely covered. And plaque as a biofilm is unique. And calculus, in case we can keep it clean, it is actually many a times used as a bone grafting agent also. We crush calculus. There are a lot of studies in which a normal mixer grinder has been used to crush calculus and use it as a bone filling agent. So calculus as such is sterile, but what you told was very correct, that as a secondary factor, it provided a nidus on which plaque formation occurs. Okay. So, and again, when we are giving the references, especially, we have to make sure that the latest editions of the textbooks are mentioned in the references. So, Hussain, otherwise yours was a very confident presentation, but Linde currently, if I remember right, 6th edition is going on. So like instead of 4th edition, we could have written 6th edition, but not an issue. Again, you have excelled. Again and again, I say, we wouldn't be turning this thing into a viva as such. You people have excelled in the presentation. So on a lighter note, I would like to finish that all three of you, would you be practicing dental surgery, dentistry later on, or you are planning to only give seminars and then later on go in for a different stream for your livelihood? So all of three of you, are you presenting, at least you can nod or say no like this. Are you planning to earn your livelihood from dentistry later on or not? Yes or no?
Yes, sir.
Okay, yes. So please remember, with regard to dentistry as a livelihood, okay, all studies, be it in America, Europe, or India as such, have pointed out to a single procedure which is most profitable, much more than implants also, much more than root canal treatment and crowns also, much more consistent, less investment and more returns over a long period of time. And that procedure is scaling. This is one thing which has been repeatedly found in this thing. And I'm not joking, just now, the 1,500 rupees which I earned in my clinic in the evening, just now towards the end, that was from scaling only. So please understand, once you have mastered the art of identifying calculus, how much is remaining, how much you have been able to remove, and the art of removing it painlessly, that is the part which will determine your livelihood. And that is one aspect which we could have added in the presentation in the applied aspect, that is scaling part. That once we remove calculus, what all precautions we can give, because once calculus is removed, we have root surfaces which are exposed. So ultimately a desensitizing toothpaste, etc. should be advised. But then again, already I was expecting this much and I got this much already. My expectations were good, but I had not expected that you people would be excelling to this much of an extent. So heartiest congratulations. As a third year graduate, you people have excelled. My congrats to all of you. Thank you.
Thank you, sir.
Thank you, sir.
Thank you so much, Dr. Mayur Kaushik sir, for your words of wisdom. It was just a lot of knowledge and a lot of to get in. Thank you so much. So next, I would like to request Dr. Anupam Podder sir to please throw your questions to our participants.
Thank you, Dr. Samiha. Just like wonderful. I would like to say, just like Asad sir and Mayur Kaushik sir, the wonderful presentation. I am very much confused about marking. Very much confused to marking. I am very happy for three presenters, nice presentation, but some drawback to Dr. Rakib. Mr. Rakib, you said you slide even you write content,
Yes, sir.
not content, not content. Content is the content, not content. Okay, and there is no reference in your slide. No reference. You must add your reference. It is important thing. And Dr. Samiha, Samiha, Saiyara,
Yes, sir.
you have no reference. You must add.
Sir, I have mentioned at last. Sir, I have mentioned at last slide.
Slide reference.
Yes,
Sir,
sir.
I mentioned
Yes, sir.
last.
Sir, I have
references.
mentioned last slide.
Okay. Okay. And you mentioned.
Sir,
and
even
and
I have mentioned it.
You mentioned. Maybe not. I probably not. You not mention you slide reference. And Dr. Mr. Shariar, you make more time. You make more time than only your time is 10 minutes, but you take more than 10 minutes. I think it must careful in future. And I have two questions from three presenters. If anyone may hand raise and give answer. What is the calculus index? What is the calculus index?
Sir, there 0, 1, 2, 3. In case of 0, there is no calculus. In case of 1, 1/3 of tooth surface is covered with supragingival calculus and there is no subgingival calculus. In case of grade 2, there is 2/3 of tooth surface is covered with supragingival calculus and there is mild subgingival calculus present. And in case of grade 3, there is huge and maximum amount of supragingival calculus and subgingival calculus also present.
Dr. Mayur Kaushik, please.
Yes.
I want your opinion.
Definitely, sir. Sir, you are telling which particular index, Samiha, then in this particular case? You're telling it as a part of some particular index,
Sir, I can get your question. Please repeat.
meaning the index which you told right now was given by which author, Samiha?
Sir, I have just read it, but can't recognize right
Okay,
now.
so
Sorry, sir.
exactly. So the green and vermilion part of OHIS index. That is what you are trying to tell right now, right? So what sir asked was that how do you assess the amount of calculus objectively? Like suppose I say mild, moderate, severe, that would vary from person to person. That would be subjective. So objectively, what you are telling is correct, 0, 1, 2, 3. But then which author are we quoting? Whose index are we quoting? So that thing we have to write. So green and vermilion, part of OHIS index you were telling. So
Okay, sir.
nicely told.
Thank you, sir.
I have another question. How you diagnose clinically subgingival calculus?
Sir, by using curettes.
Periodontal.
How you diagnose clinically subgingival calculus?
Sir, using probes.
Using probe, but how you find the subgingival calculus remain or not? How you diagnose?
The surface will be, sir, rough.
Hello?
Sir, we couldn't hear you, sir. Can you please repeat?
Sharia? Anymore?
Sir, the subgingival area will be rough if there is presence of calculus.
Anymore? Dr. Mayur Kaushik, please.
Sir, what you're telling is correct, but then again, Hussain, like the roughness criteria is a subjective thing. It will vary from person to person. So normally, whenever we have to feel anything on a hard surface, the tactile sensitivity would be enhanced if the tip is sharp. So which instrument has a sharp tip, Hussain? Explorer or a probe?
Explorer.
An explorer has a sharp tip, right? So always a sharp tip would be used with regard to the tooth surface, and the probe would be used for detection of subgingival pockets as such, soft tissues. So what we are supposed to do is we are supposed to put the explorer into the pocket, not taking it till the base, and we are just supposed to try to move it around the tooth surface. First and foremost, if it is going inside, that means no subgingival calculus is obstructing it. Now, if we are moving it and we are getting bumps in between, that is flex of subgingival calculus. So as Samiha said, that would be grade 2 of calculus index. And suppose we are not able to insert it only and we have to raise it, then it goes inside the sulcus and now it goes smoothly around the tooth surface. That means the tooth surface is covered with a band of subgingival calculus. So that would be, as the calculus index told by Samiha, score 3 of calculus index. Okay. So roughness is something which you won't be able to feel with a probe, Hussain. Are you getting my point? The tip of a probe is supposed to be put into the soft tissues for detecting probing depth. The tip of a probe is not meant from a tactile point of view to be felt on hard tissues. For hard tissues, tactile sensitivity, we have another instrument known as explorer. Are you getting it? So very relevant question as Anupam sir asked, detection of subgingival calculus. And another thing which can be done is visual, meaning like you try to dry the tooth, you try to give a blast of air from your 3-way syringe, and that leads to some amount of reflection of the gingiva. So at least you might be able to visualize a little bit. And then to confirm, it has to be done by tactile sensitivity with the help of your explorer. Are you getting my point, Hussain?
Yes.
Hopefully, in the future, all of you would be joining Perio only, sir.
I would like to encouraging them to come in periods. But
Definitely, sir.
it is very much neglected in our country because only three to four actual periodontists in Bangladesh.
Okay,
But
sir.
in case of your country, 7,000 periodontists, 7,000 plus.
Yes,
But in
yes,
our
sir,
country,
yes.
only 3 to 4%. So we are very much in the neglected condition. Hopefully, we were trying to joining type of program. This is a public awareness program. This is the paper presentation competition and seminar. And in future, I would like to invite you as a speaker in our next session.
Honor for me, sir. Honor for me, sir.
Okay.
Rather, sir, like from our university, sir, Swami Vivekanand Subharti University, Meerut, in India. Ours is a huge university, sir. Like it has 20 different colleges in the campus itself, sir. So straight away, it is my humble request to the participants. You people have a very bright future if you are excelling so much at the third year BDS level itself. So in case you people are there on Facebook, Instagram, etc., you people can send us a request and I'll send you a link for the university and department page also. So the mind doesn't see, the eye doesn't see what the mind doesn't know. So ultimately just have a look at our department page, at the page, what all procedures can be done in perio once we get a scope. So as sir said, like, sir, not on a daily basis, but let's say on a weekly basis, 1 or 2 implants I place, and we do a lot of perio surgeries also. So once you people have a look, that is when we become aware that dentistry can be divided into restorative branches and surgical branches. Surgical branches are only two: oral surgery, emergencies, and periodontal surgeries. So periodontal surgeries is all about implants, connective tissue grafts, bone grafting, etc. So I'll just cut it short, sir. I would request you to get connected on our Facebook page and Instagram page. You can send me a request first. My name is Mayur Kaushik, as you know. So I'll send you a link to our department page then. So just have a look whenever you are free. That will make you understand the applied aspect even better of calculus, implants, anything which you are interested in, sir. Thanks, sir. Thank you.
Thank you.
Thank you so much, all the respected teachers, for your questions. And I hope the audience loved the today's episode, as I enjoyed a lot. So for the judges, I would like to mention the times of each participants. For Dr. Rakib Hasan, it was 6 minutes and 30 seconds. For Dr. Samiha Saiyara, it was 9 minutes and 54 seconds. And for Dr. Shahriar Hussain, it was 11 minutes. So I hope this helps in your judgment, and we are eagerly waiting for the results. So I would love to tell the audience about our next session. The next episode is scheduled on 24th August at 10 p.m. and the group name is Furcation, and the topic will be chronic gingivitis. The participants are Nusrat Jahan Saima from Chattogram International Dental College, Proma Ghosh from Kumudini Women's Medical College, Faiza Farhan Roshbi from Dhaka Dental College. So thank you so much, the respected teachers, and again, the participants and the audience for being a part of this episode for today. I would like to seek permission from our honorable teachers. Can we end the episode today?
And heartiest congratulations to you, Dr. Saima, for an excellent moderation. Heartiest congratulations.
We also give mark to our moderator.
Okay, no competition is there, right? She is the only.
Yes, sir, but I was nodding my head when you asked about if I want to practice dentistry. And I was trying my best to be a part of it.
Definitely.
Thank you.
Okay.
Hey, Mayur.
Yes, sir.
Yes, please correct Dr. Saima. Saima sent me that means gummy smile. You correct gummy smile. You are the specialist to make treatment of gummy smile.
Of course.
Thank you.
Thank you.
Thank you. Thank
I
you.
think so.
Sir,
Okay. No, thank you. Thank you for wonderful presentation. Thank you.
Thank you, sir.
It was a wonderful. I
স্যার
really
খুব ভালো হয়েছে স্যার। স্যার আমি আসলে খুব খুশি হয়েছি স্যার, তিনজনে যা করলেন আমি তো আর কোনো মার্কিং এরই পাচ্ছি না, আমি যে কিভাবে
ঠিক
মার্ক
আছে।
দেবো আমি।